10 and ended at 4:10. Assemblymember Carr, you can begin.
Thank you so much, Madam Chair. I would first like to recognize the thorough committee analysis and accept the proposed amendments, and I really appreciate the hard work and many hours put into this by the committee staff and by you, Madam Chair, as well. Assembly Bill 2200, the California Guaranteed Healthcare for All Act, is the policy framework for a single-payer healthcare system driven by quality of care, not profits, that is efficient, not weighed down by administrative waste, and that builds a thriving healthcare network upon a foundation of equity. The last time this committee passed out a policy bill on single payer, the world was still healing from a global pandemic that exposed serious vulnerabilities and inequities in our current system. It was during this once-in-a-generation moment that many questioned our status quo system, a system that incomprehensibly ties access to healthcare to employment, a system that through costly co-pays and deductibles cruelly forces people to ration the care they need, a system that pays the most among high-income countries for some of the worst health outcomes, a system that allows thousands to die and millions to go bankrupt every year. So where are we now? According to a recent 2023 health survey, nearly 2/3 of Californians are worried about unexpected medical bills and affording out-of-pocket costs. The average cost of family premiums for job-based coverage climbed 7% to nearly $24,000 per year in 2024. Last year, 46% of U.S. adult workers with job-based coverage reported having difficulty affording their health care. That's millions of workers and their families. And over half of workers have a large deductible. What does that mean for practical purposes? That means that they're choosing whether they can afford to actually access the health care they supposedly have or not. Healthcare affordability is a top issue for Californians, and many are unable to afford the high cost of care or fear losing their coverage in an economic downturn. Even with the expansion in Medi-Cal, 2.6 million in California will remain uninsured. As many on this committee know too well, we have some of the worst health disparities, and vulnerable populations face greater risks and less access to safety net programs. Black Californians have the highest rates of infant mortality. People of color in California are 20% more likely to have asthma and 10% more likely to be diabetic. The hospital death rate among racial and ethnic categories is practically 10% higher across the board compared to white Californians. Millions of Californians live in areas with acute shortages of healthcare professionals. More than 1 in 5 Californians live in a primary care shortage area, and more than 1 in 4 live in a mental health care shortage area. We hear about hospital closures on the regular, every day, in rural communities and in urban communities. It's for these reasons and a refusal to accept our status quo that I bring AB 2200 for your consideration. AB 2200 would enact a comprehensive framework of governance, benefits, program standards, and healthcare cost controls for a single-payer healthcare coverage system in California. This system would be called CalCare, and it will be available to all California residents. CalCare is designed to cover all medically necessary and appropriate care as determined by a patient's treating healthcare provider or integrated team and consistent with the patient's best interests. Californians will have access to comprehensive healthcare coverage, including and not limited to all primary and preventative care, hospital and outpatient services, prescription drugs, dental, vision, audiology, reproductive health services, maternity and newborn care, gender-affirming care, long-term services and supports, mental health and substance abuse treatment, laboratory and diagnostic services, and ambulatory services. At its core, CalCare is a simplified public payment system for quality care to our healthcare providers that will set fair rates based on Medicare, but can be adjusted to attract a certain optimal result or ensure adequate reimbursement for services rendered. Instead of hospitals barely getting by or charging consumers unattainable prices, CalCare would negotiate global budget for institutional providers like hospitals, facilities, and clinics so we can actually fund what should be a public good. Healthcare providers will have the ability to appeal the CalCare board for an alternative rate or make adjustment on their budgets in a transparent manner. Finally, the global operating budgets for hospitals, clinics, and other institutional providers include funding for graduate medical education. We have made amendments to the last version of CalCare. Specifically, we added a public retirement benefits advisory panel, Office of Health Equity, more detail on special project budget towards rural and medically underserved areas, fee-for-time payment models, and emphasis on care coordination and prevention. We're also taking special attention at addressing our healthcare workforce shortage and retention in a number of ways. For example, a main tenet of CalCare's methodology is maintaining an optimal workforce to deliver quality and equitable healthcare. AB 2200 has provisions to increase payment rates in areas that have provider shortages. The CalCare Board will be able to increase payment rates to improve the availability and accessibility of healthcare, and CalCare includes a special projects budget to be used to increase payment rates to improve the availability and accessibility of healthcare services in rural and medically underserved areas. Up to 1% of the entire budget will be dedicated to programs providing healthcare workforce education, recruitment, and retention, and there will be a CalCare Health Workforce Group that will continue to identify efforts to improve workforce and address issues of attrition. Special projects in CalCare will fund the construction, renovation, or staffing of healthcare facilities in rural or other underserved communities. It will also prioritize those projects that address the health inequities that pervade today. Full equity in our health system will only be achieved through a single-payer system of guaranteed health care for all. The Office of Health Equity, now in CalCare, will support the board through data collection, analysis, and recommendations on issues that include barriers to care and access, equitable distribution of healthcare services, discrimination in healthcare settings, and more. Study after study has shown that a single-payer healthcare system with comprehensive coverage for all would produce massive savings on healthcare costs. As a result, California could provide better healthcare coverage to all and do so for less money than our current system. By simplifying our healthcare system, CalCare would save billions in administrative costs. By directly negotiating prescription drug prices and provider payments on a statewide basis, CalCare would be able to lower prices for drugs and healthcare services, resulting in substantial savings overall, also in the billions. The Governor's Healthy California for All Commission found that under a single-payer model with no copays or other cost sharing and with benefits that include long-term supports and services for all, California would save between $32 and $213 billion over 10 years compared to our current system. Opponents will say California can't afford to sustain this system, but the Commission also found a higher rate of growth in spending to our current system, and under a single-payer system, the gap of funding needed is $16 billion less than what California has already paid for employer contributions, premiums, and out-of-pocket expenses that our status quo requires us to pay. The reality is that CalCare is not only good for California businesses, it is good for California businesses who are being pummeled with year-over-year insurance premium increases with no ability to negotiate or push for some sense of moderation. The Commission conducted polling that found that 65% of Californians with low incomes and 72% of Californians of color with low incomes support a proposal to replace all Medicare, Medi-Cal, Cover California, and private job-based insurance plans with a single statewide government program that would cover health care for all people who live in California, regardless of income. CalCare will save lives. The Commission reported a universal health care system would save an estimated 4,000 lives every year in the state. Inevitably, someone will ask how we will pay for CalCare, especially in today's budget climate. AB 2200 is the policy framework and a policy bill that's needed to engage the federal government on a consolidated waiver, and there would need to be a fiscal analysis on what funding will be needed to fully transition and implement it. This may take years, but we should and must act now and make progress on the policy, or we don't even get to any point of discussing how we can create real cost savings for Californians. Members, we have an opportunity to set the stage for universal, affordable, equitable healthcare justice for all in California and be a model for the nation on what a progressive alternative to our fragmented, profit-driven status quo would look like. Imagine for a moment how California would have fared under a single-payer, universal healthcare system during the COVID-19 pandemic. People that immediately lost their jobs will still have their health care. Hospitals would not need to worry about a pay source. The state would be better coordinated on providing access to vulnerable communities and directing critical healthcare services like PPE and vaccines. And most importantly, lives would have been saved. One published study examined the potential benefits nationwide and estimated that the United States would have saved 212,000 lives in 2020 alone, and that $106 billion of medical expenses associated with COVID-19 hospitalizations could have been averted. CalCare is not just a healthcare justice bill. It's a racial justice bill. It's an economic justice bill. It's a gender justice bill. It's about affirming the fundamental right to health care, a right that should never, ever be contingent on your job, on your wealth, or where you live, or where you were born. With me to provide supporting testimony is Michelle Gutierrez-Vo, an RN and president of California Nurses Association, Carmen Comste, policy specialist with the California Nurses Association, and Ishmael Almendarez, president of the Oakland Educators Association and representative on behalf of the California Teachers Association.
Thank you. And just as a reminder, you will all collectively have 10 minutes.
Can you hear me? I'm Michelle Gutierrez-Vo. I'm a president of the mighty California Nurses Association, and I've been a registered nurse for over 26 years, representing over 100,000 RNs across the state. CNA is a proud sponsor of AB 2200. As a nurse in an adult family medicine outpatient clinic in Fremont, I witness preventable health care tragedies every single day that result from our profit-driven system of insurance. Patients forgo the medication and care they need simply because they cannot afford it. Meanwhile, health plan middlemen deny care to boost corporate bottom lines. I cannot tell you how many times a day I work 5 days a week in the last 23 years at Kaiser as a charge nurse of the clinic. I cannot tell you how many times a day I have to beg my patients who work 2 to 3 jobs just to pay for healthcare insurance they have no intentions of using unless they are dying. I would like for you to take a pause and remember that statement, because I don't want to waste today unless we move forward. They are counting on us. As the COVID pandemic ruthlessly demonstrated, high healthcare costs and poor health outcomes persist because access to an insurance plan is not the same as guaranteed health care for all. Our current profit-driven system is deeply inefficient, unaffordable, and unsustainable for California and our patients. It is designed to squeeze every dollar and cent from our health. As a nurse, I have a professional duty to ensure that my patients receive the therapeutic care they need. This is why union nurses advocate for a universal guaranteed health care for all under a single payer system. The legislature must act with urgency to pass CalCare because any delay will be paid through the health and lives of our patients. We must act now. CalCare would establish a single standard of care for all Californians, regardless of income, regardless of employment or immigration status, and regardless of whether an insurance company thinks we are profitable. Everyone gets the same high-quality care. Everybody in, nobody out. Study after study has shown that a single-payer system like CalCare is the only solution that would allow everyone to get the care they need while reducing healthcare spending overall. With CalCare, California would save lives and save tens of billions each year. This savings would go towards providing comprehensive care to all. In other words, CalCare would control costs without resorting to care rationing. Importantly, CalCare would not only save money, but it would improve their lives and practice of nurses like me and doctors like you. We'd spend less time and resources navigating insurance and have more time for our patients, resulting in better care. For our union members, CalCare takes health care off the bargaining table permanently. This gives us more bargaining strength to win better working conditions, safe staffing, and other protections on the shop floor. This is why CalCare has the endorsement of dozens of California unions, which represent over 2.3 million union members across the state. As union nurses, we understand that CalCare is an act of solidarity by placing every person in California into one system. In solidarity with one another, we would come closer to achieving health equity. It is my duty as a nurse to advocate for my patients and end suffering under our tiered system of care. Healthcare must be treated as a human right, not a commodity. We urge you to vote in support of CalCare today so we can begin to heal our broken healthcare system. Thank you so much for your time.
Good afternoon, Chair Bonta and committee members. I'm Carmen Comsi, Lead Regulatory Policy Specialist with the California Nurses Association. Since last session, we've worked diligently to incorporate feedback from legislators and stakeholders, and we want to thank you again for your time today, and I want to touch on some key components. CalCare is ultimately a reinvestment of our healthcare dollars into care instead of ballooning prices, administrative complexity, and corporate profiteering. On savings, the Healthy California for All Commission also found that it would save $40 billion each year on insurance administration alone. And when it comes to receiving care, CalCare eliminates insurance barriers and financial barriers to care. CalCare creates one network of providers spanning the state where care would be free at the point of service. With CalCare, we would get more, pay less, and provide comprehensive benefits and high-quality care to everyone. This framework importantly establishes the policy legislation required under federal law to begin negotiating federal waivers needed to incorporate public programs into CalCare. For provider reimbursements, CalCare aligns payments closer to cost and uses our bulk purchasing power to win fairer prices for everyone. For rural and underserved areas, payment rates would be adjusted upwards to ensure that they have the resources they need to stay open. By stabilizing funding for hospitals and clinics throughout the state, we can finally combat the epidemic of healthcare closures in rural and less affluent areas and for communities of color, which leads us to a really important point of CalCare. It creates the framework to begin dismantling the structural racism and structural health inequities that our current system is built upon. A new Office of Health Equity would identify distributional gaps in our healthcare infrastructure, and it would develop programs to address disparities in rural and medically underserved areas, including programs to meet the cultural and linguistic needs of all patients. Savings from the elimination of insurance administration and profiteering could be used for additional staff, extended office hours, or hospital renovation and construction, and to boost healthcare staffing and other resources. The bill includes provisions on healthcare workforce recruitment and retention. Programs and funding would be available to build a diverse workforce pipeline and to keep nurses and other healthcare workers in good, safe jobs with safe staffing levels while they care for patients. Passing CalCare's policy legislation today is an important first step that California needs to take on the path towards implementing guaranteed health care for all as a right. Thank you.
Good afternoon, Madam Chair and committee. My name is Ishmael Armendariz, and I am speaking on behalf of the California Teachers Association, and I'm a very proud special education teacher and president of the Oakland Education Association, 3,000 members strong. I'm here to talk about how CalCare would improve education in California. I want to just make a couple of points. So we bargain healthcare. This year, we were collectively bargaining with our district and with Kaiser, and Kaiser came with a 25% increase to our healthcare in 1 year. Now imagine this. They came with their slides. The first slide said, 1, you have a lot of women. You employ a lot of women. The second slide said, your birth rates have gone up, which cost money. Then the third slide said, you employ a lot of people of color and they're expensive to employ. Because of this, your rates are going up 25%. That is money that is coming out of our classrooms, money that is intended to retain teachers and to keep teachers in our already systems that's driving us out. So by taking healthcare off the bargaining table, that would allow us to invest into our classrooms, to retain teachers because teachers are leaving the classroom. We can invest in teachers. We can invest in services such as counselors, social workers, nurses. But more importantly, it ensures that every single teacher and every single student and every family that comes into our classroom has access to high quality healthcare. And that is why we support this. So I urge you to support the bill, to vote for the bill, and I urge you to stand with California nurses and stand with California teachers, and let's get this done. Thank you.
Thank you. We'll now have primary opposition come forward. You'll collectively have 10 minutes.
Thank you, Madam Chair and members. Nick Luizos with the California Association of Health Plans. CAP represents 40-plus state-licensed health plans in the state of California, delivering high-quality and coordinated care to approximately 27 million Californians. Our members operate in all markets, individual, employer, and public programs like Medi-Cal. CAP also supported the Managed Care Organization tax last year, which is a tax on our members and our consumers, more specifically your constituents, to invest more money in the Medi-Cal program to improve rates for providers and improve the delivery system. CAP is part of a coalition that is strongly opposed to AB 2200. Our coalition consists of doctors, hospitals, employers, and others that are strongly opposed to this bill because it is too costly, eliminates choice, thrashes our existing delivery system, and ignores the hard work that we have done in California and the hard work that we are still doing. Overall, members, it makes zero sense to replace our current healthcare system with a costly, untested new system that would hurt patient care, especially when we're making strides on affordability and are so close to achieving universal coverage in the state of California. Thanks to actions by this governor and the state legislature, California is closer than ever to achieving universal health care for all. Since Covered California's first open enrollment period in 2013, Californians' uninsured rate has fallen from 17.2% to just 6.5%. Nearly 1.8 million people enrolled in Covered California plans during the most recent open enrollment period. That is a record number of health insurance signups in the state. With new policies beginning in 2024, virtually all Californians will have access to health coverage. And we continue to make strides in making healthcare more affordable for low and middle income Californians. New subsidies provided under the American Rescue Plan have significantly improved access to affordable healthcare for all. Covered California is also in the process of implementing cost-sharing reduction subsidies for people at Covered California. Currently, 2/3 of Covered California's customers are eligible for comprehensive coverage at a cost of less than $10 per month. Additionally, the Office of Healthcare Affordability is on the verge of setting a statewide spending target in healthcare that will encompass virtually all sectors. CAP supports a workable multi-year spending target as well as the overall mission of the Office of Healthcare Affordability. Members, one thing that you hear from the supporters of this bill is that Californians are opposed to or believe that we should completely change over our existing healthcare system. And we have found that Californians are satisfied with their health care that they receive for themselves and their families today, and actually want to build on the progress that we've made under the Affordable Care Act and not start over with a new healthcare system. And yet today we're considering a massive, costly, and untested system that would destroy the progress that we've made thus far. A recent LAO, Legislative Analyst's Office analysis of this bill, or single payer, I should say, not the specific bill, single payer legislation in the past pegged the annual cost of single payer at roughly $500 billion annually. That is more than twice the typical state budget. And we don't have a funding plan associated with this bill, and we'll hear more about that later. Almost half of the funding, roughly $200 billion annually, would require a waiver from the federal government in the form of congressional action. Even if granted, this could be revoked by a later Congress, leaving California's single-payer system, if it is enacted, with a massive budgetary shortfall. The other half of the funding, around $250 billion, would be paid for by taxpayers in the form of higher taxes on jobs, income, services, and more. If the congressional waiver does not happen or gets revoked, the taxes would need to be doubled, roughly. Californians, by and large, oppose the tax increases that would be necessary for a single-payer system. And access to quality health care, if one of the other things, that you hear from the supporters of this bill is that other countries have enacted some sort of single payer paradise in other countries, but if you really look at the evidence, access to quality health care has suffered tremendously in other single payer systems. According to some studies, the median wait time in Canada, a country with a single-payer system, between a referral for a general practitioner to a specialist procedure is 27.7 weeks. That's in contrast to the wait time in the United States, which is under 30 days, about 26 days. Also, Britain's National Healthcare Service is in crisis as it deals with the lack of facilities and equipment, cost increases, and an exodus of healthcare providers in that system. Indeed, some providers that are just starting out in the British healthcare system are paid less than baristas and fast food workers in that country. And so I don't know how you would be able to sustain a workforce necessary to keep the system going. Members, as you know, California is facing a massive budget deficit. Our priority should be safeguarding the existing programs and services that we have in place now, not passing legislation for a $500 billion healthcare system that has never been tested. Single payer would force all 39 million Californians out of their existing coverage, including Medicare, employer-based coverage and covered California plans into an untested system with no ability to opt out. Californians oppose single payer that offers no ability to opt out or to choose private coverage. They oppose a single payer system that eliminates Medicare as an option for seniors. Californians want the right to choose private coverage. Instead, single payer will eliminate patients' choice of coverage and could endanger their choice of physicians, hospitals, and other providers. California would lose doctors to other states, leading to longer wait times and reduced access to care. And then members, I'll close with this. SB 770 was legislation that was passed last year, and that is initiating a process to explore the necessary federal waivers for a single-payer system. Passing full legislation is not only premature but highly questionable at this time for this and for budgetary reasons. And until whether we know a waiver is even possible for the state of California, we shouldn't be considering this bill. So, I think that's a good place for me to stop, and I'll pass it over to Preston from Cal Chamber. Thank you. We're opposed to this bill, and we urge you to vote no.
All right, thank you, Madam Chair and members. Preston Young from the California Chamber of Commerce here today in opposition to AB 2200. First, I just want to make it abundantly clear, we completely agree that every Californian is entitled to receive affordable and accessible health care. However, affordable health care coverage is different than a government-run bureaucracy propped up by monumental tax increases. If we're going to talk about single payer, then we also have to talk about how it's going to be funded. Unfortunately, AB 2200 doesn't do that. Everyone can agree the proposals contained within this bill will require taxing Californians hundreds of billions of dollars every single year. This is completely contrary to affordable health care. This unsustainable tax burden falls directly on the shoulders of California's employers, which is why we're here today in opposition. First, let's talk about costs. A piece of legislation of this magnitude and complexity should contain a funding mechanism. However, we don't have the benefit of seeing such a proposal today, so we're left to guess at how this will be paid for. It's indisputable AB 2200 will increase taxes for California's employers and employees by hundreds of billions of dollars every single year. The Healthy California for All Commission indicated that California's total health expenditures in 2022 were $517 billion. That's about 1/7 of our gross state product. According to the Office of Healthcare Affordability, California's per capita healthcare spending in 2020 was $10,299. Even assuming federal funding stays in place, AB 2200 would require a significant tax contribution per each Californian to even partially approach these figures. That needs to be kept in context. California already has the highest gas tax rate in the country, the highest sales tax rate in the country, the highest personal income tax rate in the country, the 8th highest corporate tax rate in the country, and I think we can all agree that we have a housing affordability crisis. Now, AB 2200's implementation would require layering the biggest tax increases in state history, not once, but year after year, onto struggling Californians so the state can reinvent and take over one of the most complex systems that exists in our society. Also, the last iteration of this bill included a proposed payroll tax, which I assume will be on the table again. This is worth mentioning since our state's unemployment insurance fund is insolvent and increased payroll taxes are already being assessed on our state's employers. Furthermore, if the bill were implemented, the tax increases wouldn't be static. They would have to annually grow with healthcare costs year after year, meaning the enormous tax increases would have an unremitted pace of growth. Vermont enacted a single-payer bill in 2011, but that was derailed when the state realized it risked economic shock if they instituted the 11.5% payroll tax that they planned, along with a personal income tax rate increase. Vermont's governor at the time, Governor Shumlin, stated, and I quote, "What I learned the hard way is it isn't just about reforming the broken payment system. Public financing will not work until you get costs under control." Also worth mentioning, single-payer health care would cost nearly double our state budget. This idea can't be paid for in surplus years. Now we're having this conversation when the state's facing a $38 to $73 billion deficit. Next, we oppose AB 2200 because it will drive employment elsewhere. AB 2200 will eradicate freedom of choice for consumers while heavily taxing employers who expand in California. Since this would be a state system and not nationalized healthcare, employers and employees would be free to leave so they could choose their own private healthcare rather than being forced to participate in a state bureaucracy. They'll leave to avoid the highest taxes in the country, and employers will leave to avoid enormous gross receipts taxes and payroll taxes while being able to expand elsewhere. This exodus will punish remaining Californians with higher taxes in order to offset the funding shortfall. Last, California is approaching near universal health care coverage, rendering AB 2200 unnecessary.
Please wrap up your comments.
Yes, thank you so much. We oppose AB 2200 for these reasons. We ask for a no vote today.
Thank you. I'm going to bring it back to the committee for questions or comments. I'm going to bring it back to the committee for questions or comments to be able to allow some members to be able to offer insight. Assemblymember Schiavo.
Thank you, and my apologies. I presenting 6 bills today. I got to go chair a committee shortly, but I did want to ask some questions and make some comments. And I have some questions for the sponsor, but first I wanted to ask opposition. If you could just clarify, you were talking about the $500 billion. What is that out of the study that was commissioned by the Healthy California for All Commission by UC Berkeley Labor Center?
That was the Legislative Analyst's Office analysis of the prior single-payer bill.
Right. So I think where that number is coming from, and I just hope that we can clarify that here, is actually stating what the cost of healthcare will be over 10 years if we do nothing. That's the current cost of healthcare. So that is not necessarily the cost of implementing a single-payer bill. That is the cost that we are already going to be paying for healthcare, and that study was based on from 2020 to 2030. So that 10-year, we're kind of in the middle of it, and maybe an update would be a good idea. But I think that they're referencing it. So, that same study said that we would actually save $152 billion over that 10-year period. Nearly every study that has looked at single payer has said that we will save money. It's not really debated at this point. It will save money. It will cover everyone. Those are the basic tenets of single payer. And we know that, and we see that happen in other countries. And while you quote, wait times in other countries, which I would dispute, we have wait times here. And as someone with decent health insurance, I have had to wait months when my insurance calls me and says I need to come in. They don't even have an appointment for me, and they're telling me I need to go in. And we have people who can't afford to use their insurance, and they're waiting until they die. We are the only country where people go bankrupt, and it is the number one reason for bankruptcy is medical bankruptcy every year, year after year, since I can remember working on this issue, which has been over 15 years. So we don't have that in other countries. And I understand concerns around the budget right now. I would have really loved for this to pass when it was 1,400, and when we had a budget surplus of billions of dollars, been able to set aside money to really start this program, because hopefully we would see the fruition of those savings coming in years going forward that we actually really need right now. But, to say that that we want to continue to tweak around the edges, I think is short-sighted. And anyone that I talk to in healthcare sees a fiscal cliff ahead of us that we cannot afford. Our healthcare system is unaffordable, and we know that that we have to make a change. This is the only one that saves money and covers everyone, prevents death and prevents bankruptcy. And if people want to go figure out how much they could save, there's a convenient calculator on the Healthy California website, the Healthy California Coalition website, that actually can help people calculate those dollars. When it comes to business, I would, there's a phenomenal documentary called Fix It, and it's a series. And the first one really focuses on what businesses would save. I'm a small business owner. I come from a family of small business owners. My parents in their small business would pay for health insurance for my dad's one employee before they paid for it for our family. We know that covering the cost of health insurance for businesses, especially small businesses, is crushing. It is crushing them. And so when you look at this issue for businesses, I think that this is actually a huge benefit for them, and something that they are desperately looking for change and improvement on. And it's one of the reasons that we have huge businesses like Amazon trying to create their own healthcare system, because they are so frustrated with the high cost of healthcare, right? I do have some questions that I want to ask the sponsors and better understand some of the thinking on the bill as well. And I know that AB 2200 directs the state administration to apply for federal waivers, and it does not in any way constrain what the governor negotiates with the federal government. And as a result of those negotiations will be applied by a CalCare governing board who will have complete authority to design and implement the program. I know in the last iteration in 1400, the program would come back to the legislature at a point. It looks like that's taken out in this iteration of the bill, and I just wanted to better understand the lower involvement from the legislature and what the thinking is there.
Thank you, Assemblymember Chavo, and we really appreciate your ongoing life's work on single payer. I think one of the points on the question of federal waivers, because this bill is focusing on a policy bill, and we've taken the ACA with the financing and put that aside for now. We really wanted to focus on the policy legislation, so that there wasn't any confusion about the legislature acting on a financing plan, because the plan is to be able to speak to that in the years to come after we get the policy legislation moving forward. And just, so that everyone is clear with the federal waivers, Congress doesn't have anything to do with federal waivers. It is a process that has been outlined in the Affordable Care Act with the U.S. Department of Health and Human Services, and they have very strict regulations that include a requirement that a bill has to be passed, a policy legislation has to be passed before it can actually start to consider a federal waiver. On a number of points that Assemblymember Chavo pointed out, I just wanted to clarify that the savings that the Healthy California for All Commission found, that it was very specific. It's the closest study that we have on the bill that we have before us today on AB 2200, where it includes no copays, long-term care for all. And the range just depends on how much the UC Berkeley Labor Center had estimated in terms of the increase in inflation generally. So depending on how much inflation happens, we'll save either between $30 billion to $200 billion plus. So, yeah.
And I just want to mention, the legislative authority. So that amendment, or that text you're referring to, was an amendment that was taken the last iteration when there was a separate ACA. Legislative authority will certainly be attached, particularly the financing component of it, when it does get to that at some later stage. But that being said, there is definitely a fine balance of making sure that the CalCare board's powered versus having to come back to the legislature for too much and encumbering the kind of the daily operations of CalCare being effective, but I'm definitely open to more suggestions and thoughts on it, and we can give you more background on why that was done back when on the earlier iteration in context of the ACA, and would more than happy to get back to you on that.
Thank you. Yeah, I mean, I would love to work more closely. I haven't had an opportunity to do that, as I have not had an opportunity to be a co-author. So, hopefully that can change. But I have to go chair a committee in 10 minutes, and I know other people have questions. I just want to, make just one more comment. As someone who worked at CNA for 13 years, I see friends here who I've been in the trenches with on this issue and have deep, incredible respect for the work and holding the line on this issue and moving it forward for decades. And also the staff who have worked really hard for many years. I've been there. I've been up. I have a picture of me with my daughter sleeping on the sofa while I was working on getting ready for a previous iteration of this bill until 2 a.m. on a regular basis. And so I know how much work is going into this. And at the same time, it's been decades, and it's kind of the same. It's the same approach. And I hope that this will get across the finish line this time. But if it doesn't, I really hope that there is an honest reflection on whether or not this is the right strategy. I think that there really needs to be an honest discussion around the approach that is happening right now. I have, serious concerns. We've had many years to bring together people to find resolution to big issues like the GAN limit and Prop 98. I have not heard about progress that's happening there. I hope there is, and happy for you to answer that, but I'll have to leave and I'll watch it later. I see a lot of division in the movement, and I don't think we can win divided. And I think that it's a big, complicated issue, and you need a lot of people at the table in a real way to be able to push this over the top. That's how we see big policy happen in Sacramento. And I don't see that. And so I will be supporting it today, as I have, supported it for many, many years. I really, really hope that those things change. I really do. I think that I'll leave it at that. Thank you very much.
Thank you, Assemblymember Schiavo. We are going to just make sure that we are ensuring that we have a robust conversation and also balancing the fact that we have still a very long remainder of the agenda. We are going to go with Dr. Weber, and then Mr. Jones-Sawyer, and then Mr. Patterson.
Thank you, Chair. And seeing the time, and after talking with your chair, I will keep my my questions very, very limited. Because I do want to give others the opportunity, and I also want to make sure that those who came here have the opportunity to speak. So first, I want to start by thanking the author and the sponsors. I have the utmost respect for the author of this bill. And, what you have done once again, or what you all have done once again, is to highlight a significant issue within our healthcare system, not only here in California, but within the United States. Yes, healthcare is a right, but it is not affordable. And there are so many issues, so many obstacles, so many barriers for patients to get the care that they deserve, for providers to be able to provide the care that they should. And, like I've said to many people who have come to talk to me about this is, in my opinion, something that should be discussed and passed at a federal level. It should not be something that California is trying to do alone. But it is something that we should have throughout the country. I am a little confused as to what would happen if this bill were to be passed as is, but we don't have time for me to really go into that. So my concerns, this bill has a lot of holes in it. There's a lot of unanswered questions, and this is a very, very important issue. We're talking about the health care for all Californians, current and in the future. I read the bill in its entirety, all 70-plus pages. And so I'm just going to focus on a few concerns. I'm not going to talk about the grant waivers. Other people have talked about it. I've talked about that before. I'm not going to talk about taxes for people. I'm sure other people might talk about that. One of my concerns is the CalCare Board. This bill gives this board tremendous authority. Now, they will receive state and hopefully federal money. However, it is a, quote, independent entity not affiliated with any agency or department. If you look through the bill, if you read the bill, or even just read the analysis, the things that this particular CalCare Board is over, which is the financial structure, the provider institution contracts, building maintenance, employee staffing, creating employment structure, negotiating prices for not only drugs but devices, and negotiating provider agreements. I mean, any and everything this board is over. And despite the fact that it's going to be using state funds, federal funds, there's no significant oversight or accountability or a place for the legislature to input in this board, in this bill as is. And I think that might have been one of the things that Assemblymember Schiavo was getting at. One of my concerns is that in the bill, we passed this, right? And the only thing that prohibits it from actually going into effect is it says a bill would prohibit specific provisions from becoming operative until the Secretary of California Health and Human Services give written notice to the Secretary of the Senate and the Chief Clerk of the Assembly that the trust fund has the revenues, and then the California Human Services Agency will be required to publish a copy. That's it. It doesn't say anything about once all of these things are figured out, it's coming back to the legislature so that we know exactly what we would be implementing. There's nothing in here that necessarily states that if CalCare implements a policy, it's got to come back to us. And I think we know of another commission that legislators continuously complain about that has all of this authority to go out here and increase prices, and we have no say, yet we're the ones that represent. So I'm concerned about the significant authority that you've given to the CalCare Board with no other input from the legislature. The other thing, I discussed this last week on a bill. By giving providers the ability to essentially decide what they want to do for their patient, putting it in our hands, you discard evidence-based methodology, you discard best practice guidelines, and you essentially decide what practitioners want to do for their patients, right? And that is very scary, because remembering what happened in COVID, just because I have an MD behind my name does not mean that I am practicing evidence-based medicine. And we saw that with providers saying, don't get vaccines. Take this weird medicine, right, that nobody says is correct, but I'm the provider and I think that's what's best. It also allows for continued discrimination within our healthcare system, because I, as a provider, can choose to give you a certain medication or choose to treat you a certain way, but another patient that walks through my door who looks different, who may come from a different background, a different gender, whatever, I can impose my biases in my decision. Where now, when you have standards, practice, your standards of how we practice, evidence-based approach. If you start to veer, there are checkpoints, right? And it may even be the insurance companies at time that say, we're not going to cover this medication. It's also expensive, because when you eliminate that step therapy, that says I can choose to, as a surgeon, you come in with pelvic pain, I don't necessarily have to work you up. I can just go straight to a diagnostic laparoscopy. I don't have to go through the steps to say, let me try NSAIDs, let me see if hormonal therapy works, let me try, another thing before I take you for the more expensive procedure. So, concerned about that. I've talked about this also. many times around this issue. Allowing California to continue to be competitive to get providers to come here. I am concerned with the way in which this bill is structured, that we would create a system where we would no longer be competitive to get providers nor to maintain the providers that we have, especially around specialty care. There's a section in the bill that explicitly states there shall be a presumption that Medicare fee-for-services for reimbursement constitute reasonable fee-for-service, which is interesting when just in February of this year, the AMA published an article that says, quote, what doctors wish patients knew about the Medicare physician payment system. And it highlighted the fact that Medicare rates have not kept up with inflation. And actually, when you adjust for inflation, Medicare physician pay over the last 23 years has been cut by 30%. So we are coming out of the box going to provide our providers less money and think that they're going to come or stay in practice here in California. We already have a provider shortage. And if we don't do this correctly, we'll just worsen that. We are also removing, individual autonomy, which, if someone, one of the things that jumped out at me is that if a person was eligible for an income-related subsidy, right, and they decided, I don't want it. I don't want to apply for this. In the bill, they have to. They have to apply for it, and if they do not, then they will lose their CalCare coverage, right? If they haven't applied or provided the information within 60 days, it's gone. And so I'm very concerned about some of the things, the way in which that are actually in the bill, not the concept. We have got to fix our healthcare system. But the things that are currently in the bill are very, very concerning. And the fact that if this passes as written, it doesn't come back to us at all. All of these things are done. All of these things are implemented. Let's say the money gets there. A letter is just sent stating the money is there. CalCare is off and running. And so, I think that there's a lot more work to be done. Definitely appreciate your persistence with this and the sponsors' persistence with this. But I think that this is so important that if we're able to do it, we need to do it in a manner that will actually help Californians and not ultimately end up harming them. So thank you.
If I might, Madam Chair.
I'm actually going to I'm going to establish quorum right now. My apologies. Secretary, please call the roll.
Bonta?
Here.
Bonta present. Waldron? Waldron present. Agar Curry? Agar Curry present. Arambula? Arambula present. Wendy Carrillo? Wendy Carrillo present. Flora? Haney? Joan Sawyer?
Present.
Joan Sawyer present. Mainshine? McCarty? Joe Patterson? Joe Patterson present. Rodriguez? Sanchez? Santiago? Chavo? Weber? Weber present.
We will continue with committee members' questions and comments. I'll move to Assemblymember Joan Sawyer and then go back to you before Mr. Patterson asks his question.
Okay, and then maybe I can move this along by asking Mr. Carra to answer these three questions, maybe in your summary or immediately after, and maybe we can bring this down to a level that people who are listening hopefully can possibly understand from a consumer, just from people who have to use these. As you all know, or you may not know, I'm someone that has lifetime health insurance with the city of Los Angeles. At one time, I had double insurance with both the state of California and the city of Los Angeles. Many of you have seen me hobble around this building and other buildings with a knee problem. A knee problem that I've been working through with Kaiser for the last 6 months. So I don't know where you got your specialist that you can get to people in 29 days. And it wasn't until this pain got to a 10-plus level that I finally have gotten and this is someone that has health insurance, I finally got somebody to tell me that hopefully within 2 weeks, they can tell me when they can do the surgery. And I have health insurance. Let me say this again. I'm supposed to have one of the better health insurance. And every member on this committee, every member in this building, every lobbyist have seen me struggle for over 6 months with this malady. I just hope whatever we're doing will not increase the level of care that is needed for individuals, because you'll lose me in a minute if that is the case. The reason I'm going to go ahead and move this along and do the motion is that I want to continue this, because right now it's not working for me. And in 2 weeks, when I visit my doctors and they tell me another 6 months, I will lose it. And they will be calling LAPD on my ass. Because I can't take it anymore. So that's one for me. I need to know that, and this is just for anybody out there that's listening, they just need to know whether or not this is going to improve their health quality of care whatever we do, once this is done. 2, many of you know I have a mother who will be turning 88 on Thursday. Is her birthday. We just brought her back from the hospital. For seniors out there, I'm worried about their quality of care. Right now, I pay additional insurance for her so that she doesn't have to lose her home. We don't have to go into debt to pay for her, because she has diabetes, she's on dialysis, she has heart problems, and she's probably in the hospital once a month with some kind of emergency care. And if you think about that, just the dialysis alone could be catastrophic if we had to come out of us with out of pocket. And so for those seniors who have ongoing medical maladies, we need to make sure we take care of them first. Yes, this is a nice esoteric discussion and budgets and big, but at the end of the day, I don't care. We got to take care of them. And the additional money that I pay for Medi-Cal and Medicare comes to like $600 a month. And I have insurance. So I pay another $1,000 a month for me and my mother, so that we can have medical coverage on top of what the city of Los Angeles already puts in. So that's a real concern. And then lastly, when my mother first got sick, I remember getting her credit card bill, and it had close to $12,000 on it. I said, Ma, what the heck is going on? And it was for prescription drugs. It was for about 100 pills. My Lord. At $120 each or more, $1,000. I mean, it was ridiculous, the amount of money. And it wasn't until we were able to get her into Obamacare at that time, that's how long it goes, that cost would have been incurred for her for the last 10 years. So prescription drugs and that cost is just as debilitating for people out there, whether you're poor or whether you've worked a long time and you have insurance. If I have to put out a whole lot of money going forward on prescription drugs, that is a non-starter. And so if you can answer those questions, because those are really, I think, important questions to seniors, to people who work every day, and to people who have to have prescription drugs. They need to know that if we move forward with this, that their quality of life will not go down even more so, because we make this happen.
Before any response, I heard a motion. Do I have a second? Dr. Arambula, thank you.
And I said he could answer it in his
I'll,
closing
I'll,
later.
I'll let you respond.
Would you prefer if others go and then I should give one
Why don't-
response?
Mr. Patterson, that would be great. Thank you.
Great, thank you. First of all, please, for the love of God, don't make Mr. Jones Sawyer grumpy next week or in a couple weeks. Appreciate the chair for giving me some time here. I do want to take a moment to well, first of all, make everyone a little mad, I think. But, you know, I think a lot of this comes from, you know, the elephant in the room. I mean, I've only been on this committee for a year, but it seems like a daily occurrence, whether it's in this committee or just whether it's with my conversations with doctors or hospitals or, you know, the frustrations essentially getting paid. And, you know, I just think it's, for example, just the other day, there was opposition on a bill to oppose somebody dying of an overdose, and we're going to try to get back to them in 72 hours in order for the doctor to provide that medicine. I have opposition on my bill today that would simply continue existing coverage of make sure colorectal cancer screenings are covered if some questions are brought in because of some litigation in some other state. So I think we have to get serious as a, you know, really together. I mean, I want to work with everybody to make sure that, you know, when people have health insurance and when the providers are providing that that service, that we know that it's going to be paid. Because I mean, it is a constant. I put together a medical advisory group of all sorts of people, and we couldn't even get past agenda item number 1 because it was a lot of frustrations from all my constituents that are in the medical field, and it's something we really have to address. But I do have a lot of concerns about government-run healthcare, and I'm not just saying that out of some, you know, philosophical view, but like right now I'm dealing with, you know, an issue where individuals who actually had private insurance or were on TRICARE that are being forced onto Medi-Cal, and their doctors, there are no doctors that cover their specialty developmental disabilities. And despite lots of work with the department and things like that, I mean, we just can't. I mean, they're losing their coverage right now, despite the fact that they have insurance and they want to stay on their insurance. And I thought that was all going to be solved. You know, speaking of Obamacare, I thought that was all going to be figured out there. But I actually don't. That is a problem of a government mandated system, and they really just want to keep their private insurance. And so, you know, obviously we've had conversations here about the costs and things like that. You know, obviously we're going to need some details. I do think the chamber brought up a good point about what businesses, if there's some runway, a couple years, 3 years, you know, before we really know the expenses or what it's going to cost, you know, I think they're going to start thinking like, hey, what's my long-term gain in 3 years from now? You know, maybe I should leave this state now so I don't have to participate in this expense if they don't know it, if they don't know those questions, the answers to those questions in advance. So, you know, obviously, I mean, it's probably no surprise to you. I'm not going to support this today, but you know, you're always bringing the small item issues before the legislature. So thanks for doing that. And please just don't make Mr. Jones Sawyer mad.
I'm going to have Wendy Carrillo make the last comment from committee, and then we'll give it back over to you for any comment.
Thank you, Madam Chair, and I feel it necessary to also give a disclaimer on behalf of my colleague from South LA who will not get law enforcement involved in his situations moving forward. But I do agree with a lot of his sentiment. I think a lot of us have personal experiences when it comes to lack of quality of health care, lack of insufficient quality health care, over like incredibly burdensome cost associated with health care. A lot of folks in my community of Assembly District 52, which includes East Los Angeles, Northeast LA, rely on the emergency room. and that's already incredibly costly. A lot of community clinics are becoming less and less available in our community, less and less doctors and nurses, affordability of healthcare. All of these things are true. And I really just want to bring into the space a gentleman that we lost, Addie Barkin, who has been at the front lines of Medicare for All for many years. And while we may discuss issues related to healthcare at disproportionate ages, Addie was 39 when we lost him, and we lost him to ALS. And he was a family man, husband, father, and a staunch advocate for healthcare. And we know in this movement so many people that we continue to lose because of just an inability to receive healthcare in time or preventative. I want to thank the author for all of his diligence and hard work and having the meetings necessary at the federal level to get the federal waiver to even begin this conversation as to what it would look like. And I think it's important that we recognize all the work that's being done across the state and across the country. I completely, want to say respect the opposition and their point of view, but at some point in all of our lives, regardless of who we work for, or how much money we make, or where we are in life, we will know someone that is impacted by the lack of healthcare coverage or good quality healthcare, and we will know someone that is going to go bankrupt because of their high cost of bills. We know someone that's going to lose their home, lose their livelihood, lose their job, lose everything they have because they are trying to live their life with a disease, an illness, a family member going through cancer. We've heard the stories, and there are millions of them across the country. I want to thank the advocates that are here. Some I know are here from Los Angeles and various other places across California for their continued advocacy. Some constituents of mine who are in the room or are watching back home and couldn't make the trip up here. It takes effort to come up here and have 30 seconds or 10 seconds of testimony and to, really commit any free time that you have to fight for healthcare, and not only fight it for yourself and for your families, but fight it for every person across the state of California, because that's who you're fighting for, and that's who the nurses are fighting for. So I'm proud to be a joint author, proud to continue to support the policy in a variety of different ways for the past few years, continue to put pressure on the federal government to really move forward with the promises that were made during campaigns, and promises that were made here to the 40 million people that call California home. Nothing is ever perfect. I think the conversations related to healthcare in the state are critical. We know that the state of California is coming with more and more double seniors at the same time. Lack of, again, as I'll mention, lack of professional healthcare personnel to take care of our communities. The more that we work on this, I think gives us in a better space, and more people are supportive of the work that is being done. There's a lot of work to be done, but I think we're headed in the right direction. And while I think policy committees are always hard, it's always harder to present and sit with your opposition and try to come to common ground and try to really tell the stories of everyday people who are suffering and who really want us to do what's right for them. And so I'm happy to be supportive of the bill and continue to move the conversation forward. Thank you.
Thank you, Madam Chair, and I'll try to answer some of the questions very quickly. Appreciate Senator Carrillo for long-standing support and for her comments today. As to Dr. Weber, who made some excellent points, one of the points that she made was that she believes it should be passed at a federal level. The ACA waiver process was created so that states could move forward with a variety of programs, including potentially a single-payer program. So it's been set up in a manner for states to take the lead, to be the ones that move forward with it. It's the same way that many other countries, Canada is an example, that started at the state level, and actually each state has their own program that the federal government helps to fund. And so that's the reason why we lead as a state on the policy. One of the questions she raised, also a good one in terms of giving doctors, nurses the autonomy to make that decision. the decisions, in the operating room or in the hospital room. Really, the reason why that's in there is that we don't want algorithms to override the best judgments of those that are actually caring for our patients. Now, can we tighten up the language? Because we definitely want it evidence-based, and I'm more than happy to work with Dr. Weber to ensure that language makes it very clear that we still want to make sure that they're using best practices, evidence-based practices. What we don't want to have is some algorithm or what we see nowadays, an insurance company telling a doctor that they can't do what they see as medically fit. In terms of the CalCare board having too much power, look, this bill is the policy bill. And I want to make that very clear. This is the policy bill on how the actual operation of CalCare would function. And as was mentioned earlier, there are many other steps that have to be in place, including the funding of a system that the legislature would have to approve and give authority to and release those funds to the board. So there's plenty of opportunity, and our intention is to have legislative authority through that process. What we don't want to have, and this is that balancing act, is to have every year you have to go back to the legislature to change something, do this and the other. We need the board, the CalCare board, to be able to operate independently because it is a system that's going to require that level of attention, but it does not remove legislative authority or the relationship between the legislature and the CalCare board, but more than happy to look at language that would better satisfy some of our colleagues if they think there needs to be more language in the policy bill that makes that very clear, that the legislature is not completely cut out of the operation of CalCare board in terms of especially the financing aspect of it. To Senator Patterson, I appreciate his comments. The reality is that when we talk about businesses are being fleeced right now. They're being completely fleeced, and they have very little control over how much they're being charged or how much their rates are going up year over year. If we can relieve them of that obligation, if we can relieve them of that and have them have something that's a fraction of that, which is what would happen under a single-payer program, we would actually make it more competitive for businesses to be in California, especially knowing that now they can get rid of all their administrative costs of having to worry about their employees' health care, which is an enormous cost on businesses. And let's keep in mind that Californians right now, including California businesses, are paying the highest healthcare taxes in the world. They're just not called taxes. They're called premiums, and they're called co-pays. They're called administrative costs. So we can play the game of, you're going to be taxed this and the other. Let's be real. We have the most expensive system in the world, and we do not have the best outcomes. To some of Reginald Jones Sawyer's points of these wait times, and let me tell you this. So my father's right there in the front row. I take care of him. He's on Medicare. I take him to his appointments. I know how long it takes to get an appointment. I know how much he pays out of pocket. I know he has to have Medicare Advantage, which was, again, a privatization of our Medicare system. And we're lucky that he can afford to do that. If he can't afford to do it, guess how long his wait time is going to be? Forever. And so I really appreciate the comments from Senator Jones Sawyer. Absolutely, the goal is to make sure everyone has access to high-quality care, and the reality is we can do better than Medicare. We can provide long-term care. We can provide vision and dental. My dad has to spend $6,000 for hearing aids. He has to pay thousands for dental work. That's a reality of what people are going through, and you're lucky if you're the ones that can afford it. Those are my answers to those questions.